Hello everyone, welcome to E-Classes by Dr. Adira. This video is to discuss two common oral lesions that are mucocele and ranula. Mucocele and ranula are common non-neoplastic lesions that arise from salivary glands. So let's see what is mucocele. Mucocele, as I said, it's a common lesion of oral mucosa and is considered to be a reactive lesion that affects or arises from salivary glands. The lesion usually is caused by rupture of salivary gland duct and spillage of mucin out into the surrounding connective tissue. So, this lesion is also termed as mucus extravasation phenomenon or mucus escape reaction. The lesions of mucocele is common in children and adolescents. That means it's common in young age group. And as you can see in this image, they are very common or most common in the lower lip. Other common sites of occurrence include floor of the mouth, ventral tongue and buccal mucosa. And they are very rare to occur in the upper lip. So if you find a similar lesion in the upper lip, your first differential diagnosis should be a tumor affecting the salivary glands. So as I said, mucocele is very common in lower lip as you can see in this image. And here you can appreciate a mucocele that affects the buccal mucosa. Clinically, mucocele appear as small dome-shaped swelling as you can see here. And as I said, they are caused by rupture of salivary gland duct and spillage of mucin into the connective tissue. The spilled mucin forms a mucus pooling within the connective tissue and this mucin imparts a bluish translucent hue to the lesion as you can see here. But this bluish hue is only present if the mucus pooling is located superficially in the connective tissue. And if this mucus pooling is present quite deeper in the connective tissue, the swelling will have normal mucosal color as you can see in this mucocele affecting lower lip. The lesion has normal mucosal color when compared to this lesion which is actually quite superficial in the oral mucosal connective tissue. Now let's see the etiopathogenesis of mucocele. As I said already, mucocele is caused by rupture of salivary gland duct and spillage of mucin into the connective tissue. So this rupture of duct can be due to any minor trauma to oral mucosa. Minor trauma, when I say it, include even a simple cheek biting or lip biting as well. So patient will not give you a clear history of trauma as such, because even such minor trauma can cause the rupture of salivary gland duct sometimes. So the rupture of salivary gland duct causes the spillage of mucin present within it into the connective tissue. Mucin or saliva is carried within the lumen and the duct of the salivary glands. When this mucin is spilled out into the connective tissue, it is like a foreign body to the connective tissue and it elicits an inflammatory response or an inflammatory reaction around this or surrounding this area of spilled mucin like this. So from this it's clear, or you can very well correlate the pathological findings or microscopic findings of a mucocele as well. So there is a rupture of salivary gland duct which causes spillage of mucin. So you can find within the connective tissue of oral mucosa, you can find an area of spilled mucin. And since the mucin is a foreign body to the connective tissue, it elicits an inflammatory reaction or granulation tissue response. So surrounding this mucin, you will find intense inflammatory reaction. So now you can very well correlate the histopathological features with the etiopathogenesis described. So this image is hematoxylin and eosin stained section, microscopic section of mucocele. You can see the area of spilled mucin within the connective tissue. This spilled mucin is surrounded by, or this mucus pooling is surrounded by granulation tissue response or connective tissue inflammatory response, which consists of fibroblasts, capillaries, and chronic inflammatory cells including macrophages. The macrophages present in this area functions to phagocytose or engulf the spilled mucin. And in the vicinity, you can even appreciate the minor salivary glands and ducts. Sometimes a severed or ruptured salivary gland duct can even be appreciated near the mucocele lesion under microscope, which is actually considered as a feeding duct because it is the source of this ruptured duct will be the source of the mucin spillage. So this is a low magnification view or scanner view of lesion of mucocele under microscope. The lesion of mucocele is usually clinically fluctuant and even pathologically it has an appearance of cyst, but it lacks a true epithelial lining. The mucus pooling doesn't have a epithelial lining surrounding it, so it cannot be considered as a true cyst and is considered to be a pseudocystic lesion. So now let's see the mucocele in higher magnification. When this area of mucocele is magnified, here this is the normal oral mucosal epithelium. You can appreciate here in the higher magnification the normal epithelium of oral mucosa with underlying normal connective tissue. And this is the area of mucus pooling. This area of mucus pooling is enlarged here in this image. And this area of mucus pooling is surrounded by granulation tissue response. And the granulation tissue, especially adjacent to the area of mucus pooling, shows lot of macrophages. You can appreciate lot of macrophages. These are the macrophages, which as I said, functions to engulf the spilled mucin. Since they engulf or phagocytose the mucin, these macrophages are termed as mucinophages. So this is all about the histopathological features of mucocele, and also you can appreciate the normal salivary gland and the salivary gland duct mostly with adjacent to the lesion of mucocele. Now coming to the treatment and prognosis, the mucocele are treated usually by surgical excision and removal of adjacent minor salivary gland along with the feeding duct so as to prevent the recurrence. But occasionally the mucocele will rupture spontaneously and heal without treatment. But in this case, there is always a chance of recurrence. But if the mucocele is removed with adjacent minor salivary glands and the duct, there will be no recurrence and it has excellent prognosis. Now let's see what is ranula. Mucocele that occur in the floor of the mouth are termed as ranula. Here in the floor of the mouth you can appreciate this swelling which is ranula. It originated from a Latin word rana which means frog because the swelling resembles the underbelly, the translucent underbelly of a frog. Clinically, ranula is also common in children and young adults, and they also appear as a dome-shaped fluctuant swelling, and it might be bluish or normal mucosal color like your mucocele, and they are typically present lateral to the midline in the floor of the mouth. This is an important distinguishing feature from dermoid cyst which usually arise along the midline. Ranulas usually arise as a result of rupture of sublingual gland duct and spillage of mucin into the surrounding connective tissue, which is usually above the mylohyoid muscle so as to produce a swelling in the floor of the mouth. There is a variant of ranula known as plunging or cervical ranula, in which case the mucin spilled dissects through the mylohyoid muscle and produces a swelling in the anterior portion of neck, as you can see in this image. This is known as plunging or cervical ranulas. When the cervical ranula or plunging ranula is present, along with it, concurrently, there may be a swelling in the floor of the mouth as well, but this may or may not be seen. And there is a radiographic sign for plunging ranula which is known as tail sign or comet sign. You can see here the lesion of ranula in this CT image. This can be appreciated in CT as well as in MRI imagings. So in this image, you can appreciate the lesion of ranula. This is actually originating from the sublingual space, but since it dissects through the mylohyoid muscle, the mucin or the lesion extends to the submandibular space as well. When the lesion originating from the sublingual space extends to the submandibular space like this, the lesion or spill mucin within the sublingual space appears like a tail-like extension, which is actually termed as tail sign. Etiopathogenesis and histopathological features of ranula are similar to that of a mucocele. Here, etiology is the severance or rupture of sublingual gland duct or sublingual gland itself, or occasionally submandibular duct or even minor salivary glands in the floor of the mouth, which will cause spillage of mucin or mucus extravasation into surrounding connective tissue. As I said in mucocele, the mucin will elicit a granulation tissue response within the connective tissue. So, histopathologically, the lesion is consisting of spill mucin surrounded by granulation tissue response. Even with macrophages, which functions to engulf the spill mucin. Moving on to the treatment of ranula, it is usually treated by marsupialization and or surgical removal of feeding sublingual gland. Because if you do marsupialization alone, there might be recurrence. So it is advised to remove the offending gland as well. So it is important to remove sublingual gland and duct to prevent recurrence if the ranula is originating from this sublingual gland. So that's all about mucocele and ranula. Thank you.